Welcome to the presentation, Pediatric Kidney Transplantation, Postoperative Nursing Care. Initially, your assessment and monitoring is the most important intervention as the patient arrives from the recovery room. You'll assess respiratory status and oxygenation and vital signs. You'll check the patient's neurostatus, making sure that they are arousable to gentle stimuli. Give blow-by oxygen as needed for low saturations or respiratory suppression. Notify the provider from the transplant team immediately for any initial concerns, especially with vital signs, blood pressure. You'll assess the fluid balance immediately and look at the fluid management orders. Checking the urine output from the Foley catheter, making sure that is patent. Check the IV sites, make sure they are intact and that the IV fluids are infusing appropriately. And you will make sure the patient is on continuous cardiorespiratory and oxygen saturation monitoring, preparing to do hourly vital signs, or more often if needed. Next, you'll do your full assessment, including assessing the surgical sites and skin survey. You'll assess the primary surgical sites for bleeding and the dressing condition. There may be other abdominal dressing sites from drains or a previous peritoneal dialysis catheter that had been removed. You'll look at the drain sites and the drainage in the bulb, and you'll do a full skin survey to check for pressure areas after being in the OR. Next, you'll review all of your provider orders, especially reviewing orders for IV fluids and checking your protocol orders for hourly urine replacement, and there'll be an IV fluid order for insensible losses. Review all your care orders. You'll note that there are orders for hourly vital signs and hourly fluid management. So, of course, this includes strict I's and O's, hourly calculations, and recording. Maintain patient's NPO status, although sometimes SIPs are allowed. Be very cautious about allowing SIPs in case the patient develops complications and needs to return to the OR. And finally, you review all of your medication orders, making sure to contact the provider for any confusion or clarification that is needed. So one of the IV fluid orders is to replace insensible water losses. What does that mean? Well, insensible water losses pertain to body water that is lost through normal metabolism. The water is lost through evaporation, which occurs naturally through the skin and lungs during respiration. With pediatrics, it's important to have a specific water loss calculation done by the physician, because children, of course, are much more sensitive to these water losses, especially during times of stress, after surgery, recovering, or during infections with fevers. Other things that can affect water loss would be environmental heat and humidity and activity of a specific person. So in this situation, after a transplant, it's very important to replace insensible water losses steadily. Again, we're looking at hourly fluid management. So you're measuring urine and JP drainage output on the hour. For example, from 12 noon to 1 p.m., your patient had 100 cc's of urine out and 20 cc's of drainage. So that equals a total of 120 cc's out, of course. So from 1 o'clock to 2 o'clock, you run the IV normal saline to replace those fluids at 120 cc's an hour for the next hour. And also, at the same time, your insensible losses will be replaced with the steady IV fluid. Each hour, you repeat that process of measuring the output and replacing it during the following hour. This allows to keep a close track of your patient's fluid balance. So using the hourly IV fluid replacement process for urine and JP drainage ensures that you will always have a precise measurement of your patient's fluid balance every hour. You'll have strict control of the fluid balance, and that means it will never become too negative, risking impaired perfusion, or 2 positive, risking fluid overload. So you perform these calculations every hour. That means each hour you have a new calculation for your patient's current fluid balance. You'll want to review all of your transplant kidney protocol, which will help you to review your orders and make sure your orders are appropriate. The protocol includes Q6-hour extended chem panels, monitoring for your electrolyte imbalances and your hydration status. You'll do it once a shift. Q12-hour CBC with DIF helps to monitor for bleeding and infection. The patient will have a daily urinalysis and urine electrolytes to monitor kidney function. The renal ultrasound will be performed immediately post-op and for the next 3 days. And on day 1, the patient will have a MAG-3 scan in nuclear medicine that gives very specific information about kidney perfusion and kidney function. The patient should have a weight done within the first 24 hours of surgery to determine, helps with the assessment of fluid balance. And you'll review all of your immunosuppression and medication orders. Transplant medications would include immunosuppression, of course. The patient would have received IV Campath as an induction immunosuppressant. And following surgery, the patient will continue on IV methylprednisolone and would start PO Cellcept in some cases. Later, the patient will start PO tacrolimus, but that is not started until good kidney function has been established. Sometimes that takes 2 to 7 days. And good kidney function would be evidenced by a trending downward of your B1 and creatinine and good urine output. PO tacrolimus is a lifelong immunosuppressant. However, it is nephrotoxic. So that is why you wait to start it until you see that the new kidney has developed good function. There are antibiotics on your regimen for preventing wound infection, and PO atovaquone is started to prevent PCP, which is an opportunistic infection that puts immunosuppressed patients at risk. And then there is an antiviral that is important. IV ganciclovir is given daily, pre-op and daily, to prevent CMV infection. Talking about monitoring for complications, you'll want to look for signs of bleeding. You'll watch for fever and infection. You'll be alert to hypotension or severe hypertension. Rarely, there can be hyperacute rejection that can occur immediately after surgery, which would be evidenced by high fever, unstable hemodynamics, could be change in mental status, severe pain. Of course, all of these symptoms would warrant an immediate call to the transplant team. Another problem that is more common is anuria or delayed graft function, which sometimes can occur within the first few hours of the transplant, although if it's delayed for more than a few hours, it can be a sign of ATN that sometimes can be for several days or even several weeks. It does respond to certain treatments. You'll watch out for impaired renal perfusion, again with your blood pressures, and you'll look at your chem panel for electrolyte imbalances and replace those as needed. You're monitoring and treating for acute pain post-surgically. You'll watch for signs of fluid overload, general edema, rales in the lungs, respiratory distress, and you'll also be alerted to any signs of hypovolemia, which would be perhaps tachycardia or low blood pressure. So clinical signs and symptoms of these complications in general would be fever higher than 38.5, severe abdominal or back pain, persistent hypotension, urine output that is low, urine output that starts to decrease or stops after it had been acceptable, severe chills or rigors, persistent tachycardia or tachypnea, severe hypertension, hematocrit hemoglobin that decreases, and a B1 and creatinine that is trending up, especially if it had showed a decline and then starts to climb again. That is concerning. You'll provide education, comfort, and support, of course, to your patient, explaining the nursing care to the patient and the family after they arrive from the recovery room, providing reassurance about the patient's condition and graft function. You'll provide comfort items to the child, ensure that the family is allowed to give the child their favorite stuffed animals and special blanket or any distraction tools like their iPad or anything, music. You'll review the pain management plan with the patient and family, making sure that they understand that the pain is being treated and what time the pain medicines will be given. You'll encourage the family to rest and eat. Consult a social worker from the transplant team for support and services. Provide education. The patient's immunosuppressed status is new to the family. The patient is dramatically immunosuppressed in the OR, and that will remain to be the case for the rest of their lives. The patient and the family needs immediate education about proper hand washing and infection control for all family members and visitors, and making sure they understand that there should be no sick visitors. Returning to complications, responding to some of the signs and symptoms of complications that we mentioned would usually be immediately to notify the transplant team of any concerns. Again, maintain NPO status, increase frequency of vital signs, ensure that your IV access is patent and maintain infusions as ordered, ensure patency of the Foley catheter, assess and treat for pain, accompany the patient to any diagnostics that may be needed if there are complications, and again, providing teaching and emotional support for the family and patient, especially in the face of any concerning complications. I hope this was a helpful presentation as you care for your pediatric kidney transplant patients. Thank you for listening.